Hi everyone, my name is Gurjat Basra and I'm the Manager of Patient Programs, Research and Advocacy at Lymphoma Canada, and I'm pleased to welcome you all to today's session on cutaneous T-cell lymphoma. We appreciate all those who have been able to join us live today to learn more about the disease-specific biology of this lymphoma subtype, as well as the novel treatment options available for Canadians. So before I introduce the speaker, I just wanted to provide some guidance about the Zoom software for this session. So this virtual software does not allow you to share your video or turn on your microphone. Hence, if you have any questions, please save it for the T-cell lymphomas Q&A session that follows this presentation. So without further ado, to introduce our speaker, today we have here Dr. Jory Hardin, who is a clinical assistant professor in the Department of Dermatology at the University of Calgary. She is the co-director for the Calgary Cutaneous Lymphoma Program and recently returned from a 6-month sabbatical in the US pursuing extra training in skin lymphoma. So thank you so much, Dr. Hardin, for joining us today, and I'll hand it over to you.
Thanks so much, Gurjat. It's really a pleasure to be here, and I'm thrilled that you asked me to present today. I hope you all find this useful, and thank you all for joining. I come to you today from Treaty 7 territory and Region 3 of the Métis Nation of Alberta, and I'm recording this today on the National Day for Truth and Reconciliation. As we take a moment to recognize that we all live and share this land, I want to just recognize the legacy of the residential school system and its lasting impact on Indigenous communities in Canada for over a century. Before we dive into the material, I wanted to just orient you to who I am and who our next speaker will be, my dear friend and colleague, Dr. Leslie Street. I'm the dermatology and she's the hematology counterpart of the Calgary Cutaneous Lymphoma Program. And this gentleman in the picture on the left is Dr. Gilles Lauzon, who is our friend and mentor, but also the founder of the Calgary Cutaneous Lymphoma Program in 2017. So today we're going to talk about strictly mycosis fungoides, but this is the cutaneous T-cell lymphoma classification from the World Health Organization. And you can see there's a large list of other types of cutaneous lymphomas that we could talk about in depth at other sessions, with today's focus being mycosis fungoides, a subtype of primary cutaneous T-cell lymphoma. So how do we diagnose mycosis fungoides? This is very challenging, and diagnosis is difficult, even in a tertiary setting. This is a rare condition that has a very heterogeneous presentation. It can look like a lot of inflammatory or infectious skin conditions like eczema, psoriasis, lichen planus, tinea corporis, which is a fungal infection of the skin. And patients present with variable, not just clinical, but stage of disease, often with a long history of other skin condition or being diagnosed with other skin conditions sort of preceding their formal lymphoma diagnosis. There is no single diagnostic test, and it requires, as I'll go into more detail later, not just clinical correlation, but correlation with biopsies that we take from the patient, and putting the entire picture together. Truly a full history, a physical exam, and discussion with pathology is required. That was our motivation for creating the Calgary Cutaneous Lymphoma Program, was to try to prevent some of the known delays that patients have from symptom onset. Often patients takes months or even years for patients to receive an appropriate diagnosis. And that's not just because it's a rare entity, but again, because it looks like some of these other more common things. So what are some clues? There's lots of little helpful clues. Some clue that I use often is that it presents in the bathing suit distribution, meaning area that is protected by the sun, often the buttocks, the thighs, the breasts, and even the armpits and the groin are common. So we look to see where the lesions are located. Then we look at the morphology of the lesions, or what do they look like? And typically it presents with patches and plaques of various sizes and shapes. The disease is persistent and progressive. And then another clue that I'll show you pictures of is something called poikiloderma. And that just means that the skin has combination of hyperpigmentation, hypopigmentation, atrophy, and telangiectasia. We can see in this picture, all the pictures in this presentation are of patients of mine with their consent, but this patient has large plaques, some with some more follicular prominence. They're red, which we call erythematous, and some are ulcerated or crusted. And you can see there's many different plaques at various stages of redness here. So let's look at some pictures. Here's a patient of mine again with a large erythematous patch. We use the word patch when it's flat, that has interspersed raised small erythematous or pink to red papules. And he has involvement on his abdomen, in the under the chest there, and also on the right lower abdomen. He has involvement on his buttocks as well. This patient again has more brightly red or brightly erythematous patches and plaques, some that are more scaly. We would describe these as very clearly demarcated, meaning you can sort of draw a line around where the rash begins and where there's normal skin. And this looks more like psoriasis. Here we can appreciate on the face, again, brightly red or erythematous plaques, meaning they're raised. And there's some secondary skin changes here as well, with some yellow or honey-colored crusting and scaling that you can appreciate here. Again, you maybe are getting a sense of some of these pictures, but this patient has brightly erythematous patches that are quite clearly demarcated on the central abdomen. We also know that mycosis fungoides in black and brown skin can sometimes present differently, with a hypopigmented variant becoming increasingly recognized. So these are two of my patients who are presenting not with brightly erythematous patches and plaques, but with lighter patches, hypopigmented patches on the lower legs and the abdomen. You can appreciate the same thing on the upper arms as well. But patients with black and brown skin can also have more typical mycosis fungoides, where he's presenting more with darkly pigmented patches and plaques on the abdomen, in addition to some of the hypopigmented areas. There is a variant called folliculotropic mycosis fungoides that portends in some situations a worse prognosis, and clinicians are alerted to that, not just based on the clinical morphology, which I'll review, but also the biopsy findings. So this patient has erythematous papules that are follicularly based, sort of more prominent papules at the site of where the follicles arise. And you can appreciate similar morphology in these patients where there's like a pebbling or a more prominent sort of follicle or even pustule at the advancing edge of this middle picture, and often a more indurated or thickened plaque in the forehead of this patient. These are examples of tumor stage mycosis fungoides where the patients are presenting with large, deep purple, blue nodules on the body. So this is a nice algorithm that was published a long time ago that sometimes we use to help us because, again, making the diagnosis is tricky. So there's clinical criteria, there's histologic criteria, meaning what do we see under the microscope, and then there's more refined histologic criteria in addition to molecular criteria, which means we're looking for a T cell clone, so the same malignant cell that's rapidly dividing that's causing this problem. And this picture on the left here is meant to show poikiloderma, which I described earlier as hyperpigmentation, hypopigmentation. Telangiectasia are just like pink blood vessels, and atrophy is where you can see wrinkling of the skin. So this is another picture of poikiloderma on the breast, and these are both variations of mycosis fungoides. And again, the biopsy is really important. We're not going to review it today, but to review it with somebody who has experience in diagnosing skin lymphoma and putting it together with this criteria is useful. So how do we stage mycosis fungoides? The skin staging is based on body surface area. So a patient who has less than 10% body surface area will be T1. A patient with more than 10% body surface area is T2. T3 is tumor, and T4 is erythroderma, meaning more than 80% of body surface area is involved. How do we calculate body surface area? Well, this can get tricky, but there are validated measurement tools. So if somebody has their entire back that's involved, it would be 13% of the body surface area. But if patients have specific or just localized patches or plaques, one patient hand, including the palm, is about 1% of their body surface area. So you can sometimes calculate crudely using the patient's palm. The MSWAT stands for the Modified Severity Weighted Assessment Tool, and we do this on all patients in our clinic. It is validated for use in clinical trials, and it is a weighted tool in that the percentage body surface area of patches is multiplied by a coefficient of 1. Plaques are multiplied by 2 and tumors are multiplied by 4. And you come out with a number that at the end tells you the severity of the patient's presentation, or ideally how their MSWAT has decreased following intervention with treatment. We also have patients complete a quality of life questionnaire called the Skindex 29. It has 30 questions that patients categorize answers as never, rarely, sometimes, often, or all the time. And the domains include symptoms, itching, burning, etc. Emotions, are they worried about their skin or what the prognosis is of their disease? Are they embarrassed by their skin, ashamed, frustrated? And function, so how is their skin condition affecting their relationships, ability to stay at home, how can they work, participate in sexual relationships, etc. The last scale that we use is the numeric rating scale. So, and this is for itch. Patients are every appointment categorize their itch as 0 to 10, which is their worst imaginable itch. And again, the goal is for treatment to try to improve those numbers. So what's the prognosis of mycosis fungoides? And obviously it's hugely variable as you increase in stage, but patients with overall stage 1A disease have an excellent prognosis, meaning their disease should not be life-limiting, and if treated and controlled, probably not quality of life limiting as well. And that's again, those patients with less than 10% body surface area. As patients develop tumors or erythroderma, then prognosis is altered. The Proclippi is a study, it's from the Cutaneous Lymphoma International Society, where they aim to produce a prognostic index in mycosis fungoides. They prospectively collected clinical, pathological, hematological criteria for patients, as well as quality of life data, response to treatments. This opened in 2015, and almost 2,000 patients have been recruited from over 52 centers worldwide. And we can see in patients with early stage mycosis fungoides, so patches or plaques less than 10% of body surface area, most people are using skin-directed therapy frontline, and so that's this gray bar here. Some patients get systemic therapy, and those are in patients who have plaques, extensive plaques, or like we talked about, follicular trophic disease. So let's talk about this skin-directed therapy frontline for patients with less than 10% body surface area. We use topical corticosteroids, topical retinoids, although we have limited access to a lot of topical retinoids, and then more increasingly topical nitrogen mustards, with mechlorethamine gel being a new agent on the market that we only have access to in Alberta if a patient has private healthcare coverage. And we use carmustine here, which is funded by the Alberta Cancer Registry. Physical treatment with phototherapy, such as narrowband UVB, and radiation sometimes are also used. So let's talk about topical corticosteroids. This is the most common treatment used in early mycosis fungoides. It is often the initial treatment that then gets layered on to other treatments. So patients stay on steroids for a long time. Overall response rate is excellent, although sustained response is not often seen with discontinuation. A common question I get from patients is how much do they apply? So this is a fingertip unit, and that is a line of topical steroid that's drawn from the first finger crease to the tip of the finger. And one fingertip unit is meant to cover 2 palms, including the fingers, so 2% body surface area. So if you have 2 large plaques, then you would use 1 fingertip unit to cover that area. If patients need an entire leg and foot, it would be 8 fingertip units. So you can get patients to measure out their 8 units to ensure that they're adequately applying enough steroid. Most often patients under apply steroid for fear of some of the skin thinning that the pharmacist might warn them against. As I mentioned, topical nitrogen mustard is an agent that we've had for a long time. It's initially what I recommend is patients apply it 1 to 2 times per week only, because local irritation can be quite common. After patients get used to applying it, then they can increase to every other day or sometimes daily. This is a treatment that works beautifully, but it takes a long time to work. So you have to counsel patients about being patient with its efficacy. And you can have unmasking, meaning the skin lesions seem to get worse or new lesions appear after you start with this treatment. And that's okay. That means that the body's immune system is being primed to try to get rid of some of the other lesions. Phototherapy is the use of ultraviolet light to treat skin disease, with the main entity being narrowband UVB, or for patients who have extensive plaques or deep involvement, UVA plus psoralen, which is a pill that you take that primes your body, photosensitizes the body to the UVA light. It's called PUVA. So we'll talk about UVB phototherapy. This is done 3 times a week, ideally, or sometimes 2 times a week, in a controlled setting in a physician's office where you're exposed to that very specific wavelength of narrowband UVB. Patients sometimes notice redness following the treatment, with the goal to be minimally perceptible erythema or minimally perceptible redness 24 hours after the treatment, without having a sunburn. The technicians titrate the dose of the phototherapy so that you achieve that each time you go, trying to build up some time in the booth, where initially you might be in for only 20 seconds. Over many months, you can increase that to a couple minutes. Patients wear eye protection and genital protection while they're in the booth. And if you have lesions in covered areas, you would stand in a way that allows the phototherapy to target those spots. Some of the adverse effects of phototherapy can include itching. Obviously, you don't want to burn the skin, but that sometimes happens. Patients can also get a flare of cold sores if they have, and some autoimmune skin diseases like lupus can be made worse with phototherapy. Long-term patients can get freckling or lentigines or non-melanoma skin cancer, which is mostly seen in patients who are getting PUVA therapy. And lastly, before I hand it over to Dr. Street, I do just want to mention Sézary syndrome, which is classified not under the primary cutaneous T-cell lymphomas, but under the mature T-cell leukemias. And Sézary syndrome presents with erythroderma and intense pruritus. So patients are red from head to toe, as you can see here, this patient of mine. This is another patient who has red and scaling covering her entire body with enhanced folds of the skin. And the last 2 slides I have here are just showing that erythroderma also can be seen with something called keratoderma, and that's thickening of the skins on the palms and soles, as you can see here in 2 patients with Sézary syndrome. So thanks for staying with me. That was a very quick blast of the clinical presentation of cutaneous T-cell lymphoma. In summary, mycosis fungoides presents with patches and plaques, often on sun-protected sites. The diagnosis can be very challenging and requires review of the clinical along with the pathology. And management can be skin-directed for early-stage disease. And now I'll pass it over to Dr. Street. Thank you again so much.
Hi, I'm Leslie Street, a hematologist at the Tom Baker Cancer Center and co-director of the Cutaneous Lymphoma Program in Calgary. I'm going to be presenting systemic therapy for cutaneous T-cell lymphoma. My outline is I'm going to begin by discussing a general approach to systemic treatment of cutaneous T-cell lymphoma, focusing on mycosis fungoides and Sézary syndrome. I'm going to provide an overview of commonly used treatments, review some treatments reserved for more challenging or advanced cases, and highlight side effects and potential toxicities. The goal of treatment for cutaneous T-cell lymphoma is manifold. One is to control the disease progression. If somebody has a single spot in their skin, trying to prevent it from becoming multiple spots, or if an individual has skin-only involvement, trying to prevent it from progressing to involve lymph nodes or other organs. A major goal is to manage skin symptoms, which can include burning, itching, and pain. Many patients have a priority to improve the appearance of skin for their own well-being or for the appearance as perceived by others. With this as well, a very important treatment goal is to enhance quality of life of our patients. And in doing so, we hope to achieve this by minimizing any treatment-associated side effects. There are several general principles that are somewhat unique to the management of cutaneous T-cell lymphoma. One is that skin-directed therapy is almost always used together with systemic therapy. It can take up to 3 or 6 months to achieve a full response to a new systemic therapy. So it's important not to abandon the effort early. Usually, we select milder and more tolerable treatments first. A unique principle is that we can reuse therapies that have worked in the past, unlike the treatment principles for many other cancers. Side effects may occur, but usually are reversible. It is important to consider a clinical trial when it is available. So which patients require systemic therapy? Firstly, patients with early stage mycosis fungoides, those being individuals who have not responded to skin-directed therapy alone. Alternatively, people with early stage disease who don't have access to the commonly recommended phototherapy approach. UV light treatment centers are often only centralized in major urban areas. As well, some patients with high-risk variants of mycosis fungoides may be recommended for systemic therapy. This can include individuals with large cell transformation or a folliculotropic variant. Alternatively, patients with early stage mycosis fungoides defined by patches or plaques, however involving a large body surface area, may not be amenable to skin-directed therapy alone. Other patients who may require systemic therapy include people with tumor stage mycosis fungoides. Oftentimes, these patients are managed with radiation, but we recommend systemic therapy in combination, as tumor stage disease suggests a more aggressive type of mycosis fungoides. Or patients with multiple tumors may be required to be treated with systemic therapy, as the tumors may not be encompassable within a radiation field. Patients with advanced stage mycosis fungoides, defined by those with lymph node involvement or solid organ involvement, may also need systemic therapy. And finally, patients with Sézary syndrome, defined by total or near total skin involvement with erythema, and together with this, blood involvement with cutaneous and lymphoma. I'm going to review the common systemic treatments that we use in our practice, beginning with interferon alpha 2A, pegylated version, trade name Pegasus. There was a recent global discontinuation of interferon alpha 2B. This alternative is actually preferable in that it's a long-acting, once-weekly subcutaneous injection, whereas the predecessor needed to be administered 3 times a week. This agent works by restoring balance of immune cells within the skin. We typically recommend starting with a low dose, half of the usual dose, and escalate as the individual tolerates it, and to achieve the best response in skin. We monitor for several side effects, including flu-like symptoms, mood changes, blood work abnormalities, which include thyroid and liver function problems. This treatment is very effective, and we see remarkable responses in over half of our patients. We recommend it to be continued long-term, so long as the individual is tolerating the agent and they remain in a remission. Retinoids is another class of agents we commonly use. Many of you, through your own research, may have discovered a commonly used retinoid in United States is called bixaritine. However, it's not Health Canada approved and is extremely expensive. In Canada, we use two agents, either isotretinoin or alitretinoin. Some of you may be familiar with the agent isotretinoin, which is a commonly prescribed agent for acne. For cutaneous lymphoma, it works by influencing lymphoma cell growth and causing the lymphoma cells to die more quickly. There are several side effects to note. These include dry lips and eyes, high cholesterol, and in particular, triglycerides, low thyroid function, liver injury, and also important to note that retinoids are highly teratogenic, so contraception use is essential. I mentioned methotrexate is another accessible agent here in Canada, which is reasonably inexpensive and available in most jurisdictions throughout Canada. It's a once weekly oral tablet or subcutaneous injection. Some of you may be familiar with this drug as it's also used for rheumatoid arthritis. In cutaneous lymphoma, it works by blocking folate metabolism, an essential building block for cell growth. In our practice, we find it helpful in a rare subtype of mycosis fungoides called lymphomatoid papulosis. It is not as reliable, however, in controlling most forms of mycosis fungoides. There are several side effects to note, include liver abnormalities, mouth sores, and blood count abnormalities. I would be remiss if I didn't mention radiation therapy, although this isn't strictly a systemic treatment, which is the focus of my presentation. I mention radiation because it's extremely effective to control single or cluster of tumors of mycosis fungoides. Lymphoma cells are exquisitely sensitive to the effects of radiation. It works quickly, controlling symptoms related to the skin involvement, and the skin typically heals soon thereafter. Usually patients achieve a complete response, which is something not achieved with all systemic therapies. And this can be achieved with even low doses of radiation. Because of these attractive features, we often use radiation in combination with systemic treatment. Next, I'll move on to second-line treatment and beyond. The first novel agent I'm going to describe is brentuximab. On the upper right, you see a diagram of a person with multifocal skin involvement denoted by the round circles. Beside this is the percentage of CD30 expression that each of these lymphoma tumors represent. And as you can see, some of the tumors have high levels of CD30 expression, up to 90% in this example, whereas other tumors have a small amount of CD30 expression. Brentuximab is an antibody drug conjugate, which recognizes CD30 expressing tumor cells. The antibody is attached to a chemotherapy agent, which then moves on to disrupt cell replication. It's an intravenous treatment, which is provided every 3 weeks for up to a 1-year period. There's strong scientific evidence to prove that brentuximab works in a randomized clinical trial, which was published entitled Alcanza. In this study, more than half of patients who received brentuximab responded for more than 4 months of duration, which is considered a meaningful clinical response. One of the side effects of note, which is quite common, is peripheral neuropathy, but fortunately this is reversible in most individuals. Mogamulizumab is another targeted therapy. This one is an antibody against a chemokine called CCR4, which is a marker on lymphoma cells involved in trafficking of these cells from the blood compartment to the skin compartment. As you can speculate, this is very useful for individuals with Sézary syndrome, whereby the disease is characterized by both blood and skin involvement. It's an intravenous therapy that's administered every 2 weeks and continued for patients as long as they are responding. There too is good evidence in a proper scientific randomized study entitled Maverick. In this study, responses were observed in almost half of patients who received mogamulizumab. And as I mentioned, patients with blood involvement in particular have the best responses. It is well tolerated. However, there's a few important notes. One is individuals can have infusion reactions and for that reason receive pre-medications. More important is that patients on mogamulizumab can develop skin rashes, which are known as mogamulizumab-associated rash, or MAR. This can be very challenging clinically, as we have to discriminate a rash associated with the mogamulizumab from the underlying skin lymphoma. This is done in concert with consultation with dermatology and often involves skin biopsy. I'll briefly mention a class of drugs that many of you may have researched or heard about called histone deacetylase inhibitors. Currently, the intravenous version of romidepsin has recently been pulled from the market in Canada and is no longer available. This was not because of a toxicity reaction, but rather a lack of proven benefit when compared to traditional chemotherapy. The oral or capsule version of a histone deacetylase inhibitor is called Brinistat. It still is available in Canada. It works by modifying cell proteins and growth. Response rates, however, are quite low at only 25% of patients. And side effects are common, including diarrhea, nausea, and fatigue. There are challenges obtaining funded access through Canada, and it's not funded through most provincial cancer agencies. However, some patients with private insurance may be able to obtain funded access to this agent. Pembrolizumab is a targeted therapy, a type of immunotherapy called a PD-1 inhibitor. It's used in other forms of cancer, both hematologic and solid organ. It does have efficacy in cutaneous T-cell lymphoma. It's an intravenous treatment administered typically every 6 weeks. It may not be funded or available for use for cutaneous lymphoma, depending on the jurisdiction that you are living in. It has phase 2 level of evidence, which is not as strong as a randomized controlled study that I previously described. However, response rates were observed in 38% of patients who received pembrolizumab, so may be worth trying for some individuals. It's characterized by a skin flare reaction, however, so one must exercise caution, particularly if the patient is known to have strong PD-1 expression on their tumor cells within their skin. Side effects of note that must be monitored for include inflammatory or immune reactions of the liver, lung, or gastrointestinal tract. Finally, I'll mention chemotherapy. Chemotherapy works by nonspecific interruption of cell growth. The term cytotoxicity refers to the destruction of both cancer, lymphoma cells, along with other rapidly dividing normal cells in a person. For that reason, individuals receiving chemotherapy may experience hair loss, nail changes, mouth sores, intestinal effects, blood count reductions, or infections. When required in cutaneous lymphoma, we recommend single-agent chemotherapy. Commonly used agents include gemcitabine or liposomal doxorubicin, and this is preferred over multiple agent combination chemotherapy to minimize side effects, toxicities. The objective is to lead to a remission in the skin, but it's recognized that although often achieved, it's typically short-lived, of only 4 or 6 months. Patients may not choose to endure several months of chemotherapy for such a short-lived response. Now to speak of some novel types of treatments that are unique to cutaneous T-cell lymphoma. one of which is called extracorporeal photopheresis. This is a key treatment for Sézary syndrome, and I'll explain why. As a reminder, patients with Sézary syndrome have both skin and blood involvement. The treatment of extracorporeal photopheresis, or ECP, involves removing the blood through an intravenous line into the photopheresis machine. When it is outside the body, it is centrifuged or spun, and the red blood cells and plasma components are returned to the patient. The white blood cell component, which is where the lymphoma cells reside, are put into a treatment cassette. Therein, they're exposed to a photosensitizer called 8-MOP, as shown in the diagram, and the lymphoma cells are exposed to UV irradiation. Thereafter, they're recirculated back to the patient. This whole process takes several hours and is shown in the diagrams on the right. It's highly effective for eliminating tumor cells in the circulation, and with that, patients have responses in the skin. Problems include venous access, as well as the time associated with getting this treatment, which needs to be repeated 2 successive days every 2 weeks. Also, as you can imagine, this specialized equipment and training that's required is only available in certain centers. Another specialized treatment is called total skin electron beam therapy. It's a highly specialized form of radiation which was invented in the 1960s. On the top, you see a diagram of patients positioned in various ways, and below, a person demonstrating those positions and the apparatus that the individual must stand on while receiving the external radiation. It requires complex commissioning, though, of the linear accelerator, the radiation machine, and specialized support from medical physicists. It is highly effective, inducing remissions in patients who fail all other conventional treatments, and for those in particular with extensive skin involvement, since the radiation is applied to the total body skin surface area. It dramatically improves patients who have severe skin-related symptoms. One of the challenges with total skin electron beam in Canada is it's available only in a few places throughout Canada, which I've highlighted here. There is a center in Victoria General Hospital in Winnipeg, one at Juravinski Cancer Center in Hamilton, and an additional center in Montreal. I've highlighted Alberta because that's where I'm from. We estimate approximately 6 patients would benefit from this therapy each year in our practice. However, not all patients are available to make the travel necessary to receive treatment in these centers. As we try to advocate for considering developing a program in our own province, we received some quite impactful testimony from our patients. One patient shared that the treatment I had in Winnipeg has made a radical difference in how I feel. The itch is almost gone now, and that is amazing. I saw my dermatologist today, and he was rejoicing with us. Another patient said, further treatment, travel, and accommodation expenses at this out-of-province facility would be cost prohibitive for me and my family. Another patient shared, our whole family would be thrilled if there could be a TSEB program here and you could probably insert your own province name to complete that sentence. Some of the challenges we have in treating cutaneous lymphoma in Canada include, first, the delay in diagnosis, which is quite typical for mycosis fungoides and even Sézary syndrome. It's a rare cancer, and there's fewer programs which specialize in the management of cutaneous T-cell lymphoma. There's often funding and access difficulty for some of the therapies, which are very specialized and expensive. Some of the specialized treatments that I described are offered only in select urban centers across Canada. And finally, the clinical trial landscape in Canada is minimal at this present time. In conclusion, systemic therapy does have a role for some patients with cutaneous T-cell lymphoma. It's important to understand potential risk and expected benefit of each treatment to make an informed choice. and the rarity and complexity of cutaneous T-cell lymphoma necessitates expert interdisciplinary care. Thank you, and I look forward to your questions.
Thank you, Dr. Street and Dr. Harden, for that wonderful presentation. I would now like to direct the audience's attention to attend the T-cell lymphomas Q&A session after this presentation. Thank you.